Society of India, Dr. Keshav Murthy sir, to give welcome address and opening remarks. Over to you, sir.
Thank you, Dr. Surya Prakash, and it's my pleasure to welcome all of you to this smart learning program, which is on comprehensive evaluation of male infertility by none other than Dr. Rupin Shah. We were students when Rupin Shah started teaching male infertility, and he continues to. It's a master class. If you listen to him, you will always want to keep on listening to him. He is very clear in his ideas, and his presentation is also amazing. So I hope all of you will enjoy these two classes. One is today, and the next one will be on 31st about the management of male infertility. So with this introduction, I welcome Dr. Rupin Shah for the Smart Learning Program, and over to you, Suri, for the introduction.
Thank you, sir. The Secretary of Urological Society of India, Dr. Uttam sir, is not available as he is attending EAU. Uh, Before I hand over to sir, it's my pleasant duty to say a few words about sir. As I said, sir doesn't need any introduction. It would be like saying that Amitabh Bachchan is a great Indian actor. So, but it's my bound duty to say a few words. Sir is a senior consultant urologist at H&N Reliance Foundation Hospital and Lilavati Hospital Research Center, Mumbai. He is a pioneer. He's a world leader, I can say, and we are all proud of you, sir. From India, you have done such amazing work in male infertility and andrology. Sir is the first urologist from India to be trained in microsurgery in andrology and to start take up this subspecialty as andrology and infertility as a subspecialty way back in early 90s. He has developed many innovative techniques, to name a few: microsurgical repair of obstructive azoospermia and a new technique for sperm retrieval in men with non-obstructive azoospermia. The Shah Indian penile processes, every one of us know about this innovation by sir, and it is the most commonly used penile implant in India and also in the Asia. For his pioneering role in work in infertility, sir was awarded the prestigious B.C. Roy Award from the President of India. He has conducted many national, international courses on andrology, infertility, and also operative workshops. He's currently the convener of the FNB Andrology of National Board of Examinations. He's also the founding president of South Asian Society of Sexual Medicine, senior advisor to Global Andrology Forum, and associate editor of Journal of Fertility and Reproduction. He is also a member of several global committees of International Society of Sexual Medicine, and also the first chairman of the Andrology in subspecialty subsection of Urological Society of India. He has published numerous papers, chapters, books, and holds many academic positions. Thank you, sir, for accepting this invite to give a talk on male infertility. Over to you, sir.
Thank you very much for the invitation. This is such a wonderful initiative by the USI. It allows, as we were saying earlier, students from all across the country to listen to experts from all across the country with no limitations of time, space, or expense. And I think the mechanics of the system have been perfected. The clarity of the transmission, the recording, the subsequent accessibility. It's a truly valuable initiative, which will certainly further education in urology in India. I'll start with an apology. I have quite a nasty cough, so every 2 minutes you'll hear me coughing, and I may pause to take some warm water. We've decided to hold this talk in 2 parts so that we have enough time to leisurely discuss both aspects. The first part will deal with how to evaluate a man with infertility, and the second part will be on how to treat him. For 25 years, we've been holding a workshop in Nadiad at MPUH on male infertility and sexual dysfunction. And those workshops started because at many meetings, young urologists would come to me, some PGs, some recently passed out, saying, we've read Campbell's urology, we understand the theory, but when there's a patient with andrological problem sitting in front of us, we don't know what to do practically. And particularly in andrology, I think there's a disconnect between the theory that you read and the actual practice. So in the session today and the one after 2 weeks, we're going to focus on a practical approach. So we're going to start by imagining that a patient walks into your clinic, a part of the infertile couple, sits down, and you are now expected to evaluate him further. And what do you do? And that's how we'll go through everything, explaining what tests you do, why you do it, what is the clinical next step that originates from that investigation, and to what extent can you rely on that test. And in the subsequent talk, we'll put it together into the therapeutic steps that emerge from that. We've kept a gap between the two sessions in the hope that you will ruminate over what you hear today, maybe go back, read something. And if you have any questions, I don't know how are we able to take questions today? What is the format?
Yes, sir. Yes, sir. The questions will come to a separate site. So I have the access and I'll give the questions to you.
Okay, so and few of the questions that come in today, we will answer. But if you have a thought that comes to you later, or if your question was not answered today, you can email me. Email is just my name, drrupinsha@gmail.com, no dot or hyphen or dash. And in the next session, we will start by answering some of the key questions or areas that were left unanswered. So with that, I'm going to start sharing the screen and we will start our presentations. Just adding some last minute slides. Okay, now can you just confirm that you're seeing full screen and
Sir.
hearing me clearly?
Yes, yes. Perfect.
Okay, so there's the email ID at the bottom. You're welcome to write to me. Sometimes I'm very prompt, sometimes I'm lazy, but you'll get a reply. So and we're talking fully infertility this time, maybe in future we'll talk of sexual dysfunction. When a couple or a male comes for infertility evaluation, and usually they'll be referred to you, you have three goals. One, we want to assess that how fertile or infertile is this male, or in other words, to what extent is he contributing to the couple's infertility. And that's an important phrase, because as I explained to all couples, in infertility, 2 into 2 can be 4, or 4 into 1 can be 4. In other words, you can have both partners who are optimally fertile, or you could have one who is very fertile and one who is subfertile, and still they will achieve a pregnancy. So it's always a consideration of both partners when we assess the couple's fertility. And we're going to talk of this further when we talk of some major changes in how we understand semen analysis. If we feel that the male is subfertile, then part of our evaluation is also to identify, are there any factors which, if corrected, will improve his fertility? Or are there any factors in the history or examination that tell us this man is not going to improve further, and therefore, in fact, we should not waste time on treatment and move on to the next step, which may be perhaps some form of assisted reproduction. Linked to that, we want to know whether there is a sexual problem which has created this difficulty. And just this morning, I saw a couple. Wife was 40, husband 44. And they said, Doc, we have sex maybe once a month, twice a month. We can't do it more frequent. So obviously, they're not going to get pregnant. And either we have to be able to increase their frequency, or given their age, lifestyle, schedule, work pressures, maybe they are a couple who would be pushed towards IUI or any assisted form. So again and again, I'm trying to drive home the message that it's a dynamic evaluation. It's not a mathematical algorithm like in a cancer case where you look at T and M stage and follow a flow chart. And if a couple is going in for an EART procedure, as a uroandrologist, which I hope all of you will be at the end of this presentation, you may need to identify difficulty in collection of semen and know what to do about it. And we'll talk about that and ejaculation in the next session after 2 weeks. So this is a message that I give not only the uroandrologist, but also every gynecologist, that the first step, or one of the first steps in the evaluation of an infertile male, but also of an infertile couple, should be the semen analysis. Because without this, what happens is the gynec takes every scope that they have, put it into the patient from above, from below, and when they don't find anything, then they send the man for a semen analysis, only to discover that he's azoospermic. So semen analysis is one of the very first steps. And either the couple has already come to you with a semen analysis, almost always that is the case, or if you're in a team where you're seeing couples for the first time, one of the first things you will do is ask for a semen analysis. So let's understand some practical points about how you use a semen analysis. How many days abstinence? The books say 2 to 7 days, but we need to understand this 2 to 7 days. 2 to 7 days came about because in the WHO manual, the normative data was derived from fertile men who abstained from between 2 to 7 days. Is 7 days optimal? No. If a man has good count, poor motility, maybe 1 day abstinence may give him the best semen report. When a couple is trying for infertility, they are having sex every alternate day, abstinence of 48 hours would better reflect their fertility. So for a general initial diagnostic screening, 2 to 7 days abstinence, but when you're actually giving therapeutic advice, the abstinence which is optimal for a given man and a given couple will vary. For example, we have men with cryptozoospermia, rare sperm in the ejaculate. Very often we will tell them on the day of IVF, give 2 samples, 2 hours apart, and it may be paradoxical. The first sample, no sperm, and the second sample, just 2 hours later, will have enough motile sperm to be able to do IVF. So for that man, his optimal abstinence was 2 hours, not 2 days. So just bear that in mind between the diagnostic versus the therapeutic abstinence. Of course, a wide mouth container, no lubrication. Tell them not to use soap or jelly while masturbating to give the sample. Routine condoms are spermicidal, should not be used. But if a man cannot collect semen by intercourse, by masturbation, and needs to have intercourse, there are special non-spermicidal condoms, quite expensive, almost 1,000 rupees each, which are provided by IVF suppliers. And also bear in mind that if a man has come to you for the first time and you're telling him, go give a semen sample, remember that 5 to 10% of men have difficulty masturbating. So my advice to the patient always is, before I tell him to do a semen test, I'll tell him that, will you be able to give a semen sample by masturbation in the clinic? And sometimes they'll say, doc, not by masturbation, but by intercourse, not in the clinic. I get very self-conscious, but I can do it at home. Once you identify a problem, then there are specific solutions. Allow them to collect at home, coitus interruptus, non-spermicidal condom, or even a special penile vibrator, which hopefully we'll talk about next time. Now, how do we interpret a semen report? Fine, you've got it with the optimal analysis, you've got it from a good lab, and that is important because semen analysis is a very subjective test, operator dependent. Often a poorly trained technician does the semen analysis. So over time in your practice, you need to identify a lab which is good and committed and gives a seemingly detailed report. Now, once you have a good report, how do you interpret it? The WHO manual has always been the guideline for that. There are 6 manuals now. These were the first 5. Up to the first 4 manuals, the normative data was derived from a few major published papers. So if you look at 1999, which a lot of people were familiar with, the normal sperm count was 20 million per ml of 40 million total and a motility of 50%. For the 5th edition, they decided to make it more objective. So they took data from almost 1,800 fertile men, asked them to give a semen sample, created a normogram of that, and used the 5th percentile to define what is considered normal. So in the 5th edition, the norms were a count of 15 million per ml, or a total count which is concentration into semen volume, 39 million, motility of 32% progressive. Progressive was fast and slow progressive, and morphology, and this is important, just 4% was considered normal. So this is widely known now and widely used. However, it's very important to realize that this is just an indicator. It is not an absolute cutoff. In the 6th edition that has come in 2021, they enlarged the sample from 1,800 to 3,500. But surprisingly, there was virtually no change in the normative data at the 5th percentile. You can see the count, motility, morphology changing by 1 or 2%, which tells us that this 5th percentile was fairly stable. This is the 5th edition in which morphology was defined as 4% normal, and we'll talk about that again. And this is the normogram on the basis of which the cutoffs were decided. In the 6th edition, many of the missing countries were included. So on the top 5 bars are the 5th edition, lower down are those included in the 6th edition. And once again, they use the 5th percentile. Now, what I want to highlight for you here is that all the men in this sample are fertile. So even the 2.5th percentile male were fertile. So even though the normative data was empirically decided from the 5th percentile, it is possible that men with lower sperm count, poorer motility may achieve a pregnancy. And equally important, if you take the 50th percentile, which is the average count motility of a fertile male, it is much, much higher than the so-called normative value. So in other words, we see that there is a progression and that semen analysis cannot be a simple cutoff. At best, it can be a probability. And therefore, in the 6th edition of the WHO manual, they took a very bold step. It was bold because though clinicians knew this from their practice, it was never put down in a guideline or in a journal. And in the WHO manual, this is what they finally acknowledged. The lower 5th percentile from men in the reference population, which is the table which I showed you, it does not represent a limit between fertile and infertile. In the past, doctors and insurance companies, sperm count 16 million per ml, 41 million total, you are not infertile, you're not entitled to treatment. Count 12 million, or you're infertile and there's a problem. We now know that there's no such clear-cut distinction. At best, we can talk of probability issues. So if you read the second line, and this is quoted verbatim from the 6th edition, 6th WHO manual, for an individual patient, a semen analysis is never prognostic. Not true. If he's azoospermic, it's prognostic, but otherwise, we could say is usually not prognostic of fertility, as the fertility potential of a couple is what defines them as fertile or subfertile. And as we said, 4 into 1 could be 4, 2 into 2 could be 4. And as we also know, semen analysis in general is a poor predictor of pregnancy outcomes. In fact, studies have shown that in young couples in the first 2 to 3 years of marriage, semen analysis does not distinguish between who will get pregnant and who will not get pregnant. So now when we look at semen analysis, and this is the modern trend, we look at a decision zone. So below 5th percentile, we won't say it is infertile, but we'll say that fertility chances are poorer. and therefore we are more likely to advise these couples for ART. Over the 50th percentile, we would say that increasing the sperm count, motility more than that probably will not help. But if somebody is at the 5th or 10th percentile, if through our treatment, medical, surgical, we can move them toward the 25th or 50th percentile, we may actually increase their fertility. So how does this translate to your advice to your patients? You have the man sitting in front of you, you've examined him, he has a large varicocele, but his sperm count is 20 million, motility is 40%. By the 5th percentile criteria, that is normal. But by the 50th percentile, that is still quite low. So you may not rush into surgery, but if this couple has been trying for 2-3 years and the wife is normal but still not pregnant, then you may think perhaps correcting the varicocele will move this male towards the 50th percentile, and that may increase his chances of pregnancy. So the bottom line, the take home for you is that when you're trying to assess the fertility of a male, look at semen, but also look at how long they've been trying for a child, which may be different from the duration of marriage. Look at their age, young couple versus older couple, very different fertility potential. And are there any concomitant female factors that may complicate the outcome? This is a very important slide which will illustrate what I've told you. So if you look at the left column, if the duration of infertility is short, 12 months or less, even if the motile sperm count is only 1 million, there is still a 1 in 4 chance that the couple will achieve a pregnancy in the next year. On the other hand, if the couple has been infertile for 96 months, the last column, even if the man's total motile sperm count is 10 times higher, the chance of pregnancy is only 1 in 7, 14%. So in other words, time is a filter. Many couples where the semen seems inadequate will still achieve a pregnancy if given enough time. And many couples where everything seems normal may still fail to achieve a pregnancy because of functional defect in the sperm, which is not reflected in the semen parameters. And therefore, the previous slide, that when you look at fertility, look at semen analysis, age of the couple, duration of marriage, how many years they've actually tried. Sometimes the husband is a shippy. They've been married 5 years, but they've spent only 15 months together. And then looking at a chart like this, deduce what is the fertility potential. So this is very important because it will determine how you counsel patients when you come to therapy. Now let's try and get clinical implications. When you do a semen test and get the report, you'll see volume, you'll see liquefaction time, you'll see viscosity, you'll see agglutination, sperm count, sperm motility, pus cells. What do all of these tell you clinically, other than assessing fertility, which we've looked at? Do they have clinical implications? So that's what we're going to understand. So if a man is in front of me and the semen volume is low, first thing I'll ask him is, was there spillage? Did you collect everything? Did you have enough abstinence? Sometimes they'll say, no, we had night emission, and 6 hours later we gave the sample, which tells us we need to repeat the test. Or had he had difficulty collecting, he struggled and struggled, finally collected a little which was not representative of his normal sample. All these would be indications that this is a semen sample that you should disregard and ask for a new semen sample. If, however, it is genuinely low volume, 0.5 ml, and usually low volume will be accompanied by absent fructose, just looking at that semen report, I can be 95% confident that this man has bilateral congenital absence of the vas deferens. Ejaculatory duct obstruction is also a differential, but much less common than vasoplasia. So low volume azoospermia with absent fructose, vasoplasia or ejaculatory duct obstruction. Low volume with oligoastheno, it could be a partial retrograde ejaculation or an incomplete collection. So volume is a guide to the presence or absence of the seminal vesicles, from where most of the semen volume comes. Sometimes there may be seminal vesiculitis that may have shrunk the seminal vesicles and volume may be low even if there's no retrograde and no obstruction. Now, this you will see often, altered liquefaction. Semen didn't liquefy for 1 hour. What does that mean? It means two things. One, because the semen did not liquefy, maybe the semen report will not be reliable, because unless the lab is good, they will not liquefy the sample properly and mix it up, and a sampling error can be quite common. So I'm always a little suspicious of the values reported in a sample which is not liquefied, unless I know this is a good lab which will forcibly liquefy the sample, mix it up well, and then do the testing. Otherwise, the other implication of liquefaction as well as viscosity is related to the accessory gland function. When semen is ejaculated, there are proteins in the seminal vesicular secretion which coagulate in the next few minutes, and then enzymes from the prostate liquefy it. So delayed liquefaction is an imbalance between the protein and enzyme from the seminal vesicle and prostate. Once it liquefies, if it liquefies properly, you can pour it drop by drop. But if you're unable to pour it drop by drop and it comes out as a string, that is increased viscosity, which is a function of the electrolytes and other substances within the semen. So there are different properties, liquefaction and viscosity, but they both reflect or point towards the same thing, which is an alteration in the function of the accessory glands, either due to a current infection or a past infection, and sometimes it's idiopathic. We don't find any infection, but the significance of this would be, one, in doing the test properly, and two, it becomes one of the several pointers that maybe infection is a consideration in the infertility of this male. Then, of course, you will see count and motility. Count we'll look at first, and then we'll come to motility. So low count, very common. Often it is just idiopathic, can't find a reason. The commonest correctable cause, of course, which we're all happy when we find, is a clinical varicocele, and we're going to talk about that in a moment, clinical versus subclinical. Nowadays, increasingly, it is because of external stress and toxic and endocrine disruptors. So the plastic in the cups, the plastic in the tea bag, the pesticides in the food, the toxins in the environment, the heat, the stress of traveling, the stress of work, irregular sleep, all of those gonadotoxic factors have a significant impact on testicular function and therefore on sperm count. There are, of course, rare conditions like gonadotropin deficiency, partial blocker, which mainly it is these reasons. Just be aware that if in the history there was a recent illness, then that could be a temporary cause of low count, and then you would want to repeat the semen test after some time. Now, when you come to impaired motility, you have to distinguish between oligoastheno, which means low count and low motility. Low count, low motility, and poor morphology. Oligoasthenoteratozoospermia reflects poor testicular function. On the other hand, if you have isolated astheno, meaning count is good, maybe morphology seems normal, but motility is poor, then it means that the testis is functioning adequately, but there is a defect in the functioning, so that either the sperm are being produced defective, therefore they are not motile, or there is something happening after the production, either infection or antibodies or toxic factors in the seminal plasma are getting to these sperm and killing them. So the two conditions are very different. Oligoastheno, you work on testicular function improvement. Isolated astheno, you want to understand what is the factor impacting motility, and is it mild astheno, moderate astheno, total astheno? If, for example, it is total astheno, meaning lots of sperm, all immotile, then it becomes very important to distinguish between whether these are live immotile sperm or dead and therefore immotile sperm. If they're live but immotile, that means there's a defect in the mechanism in the tail, and that happens in cartigenous syndrome. or other related conditions of microtubular defects. On the other hand, if it's all dead sperm, then there is some toxic factor acting on the sperm later on, which is killing them. So if it's necrosospermia, we may still try a course of antibiotics and anti-inflammatory and maybe steroids. But if it's cartigenous syndrome, medicines won't help. But those sperm can still be used for IVF ICSI. So the way you distinguish between viable and non-viable is by a stain called eosin nigrosin stain. If the sperm is viable, the membrane is intact and that will prevent the sperm from taking up the dye. If it's a dead sperm, the dye can penetrate through the membrane. So the sperm that gets stained by the eosin turn pink, those are dead sperm. And if there are lots of unstained sperm, then it means they're more viable sperm. Just take a break to drink some hot water. One moment. Meanwhile, you can type out your questions and post them. So this understanding is very important because this is where you may often guide your pathologist as to what is it that you want, so as to be able to guide the couple further. So if you understand it, then you're able to guide them. So we looked at count, motility, morphology, agglutination, and now we will come to morphology. Where's the morphology slide? That's afterwards. Okay. So let's look at morphology and then we'll come to pus cells. Now, morphology is something very interesting. If you look at the early WHO manual, 70% normal morphology was considered normal. If you look at the 5th edition, 4% normal is considered normal. What has changed? The criteria or parameters by which sperm are judged normal have become stricter and stricter and stricter. And the reason why you need to know that is if you get a semen sample, especially from an IVF lab, where you expect they've used strict criteria, and it says 5% normal or 6% normal, and the patient is freaking out, you should be able to tell him 5% normal is normal. In fact, 4% or more is normal. Nowadays, in fact, we take it a step further. We tell patients, don't worry, even if it's only 1% normal, because labs have become kind of over-enthusiastic. And we see lots of fertile men coming with 1%, 2% normal. And in one study of fertile men, in about 20 or 25%, there was so-called 0% normal sperm. So morphology is important, but it's kind of become like a super strict teacher who fails everybody in class. If you fail everybody, then the test has no discriminative power. So the take-home message is don't get stressed out about morphology, and don't let your patients get too concerned. Agglutination is sometimes reported. There you actually need to distinguish between aggregation, which is just immotile sperm that have clumped together, versus agglutination, where motile sperm stick to each other, either head to head or tail to tail. And there may be a few sperm agglutinating or many sperm agglutinating. If a large number of agglutinated clumps, which means motile sperm stuck to each other, are seen, this could indicate again antibodies or infection and would warrant investigation and treatment along that line. However, if most of the sperm are dead and immotile and you find them clumped together, that is just a rheological property and not clinically relevant. Now, this is very important, particularly for the urologist. Often you will see a semen report with 18 to 20 pus cells, and you jump up and down. Yes, something I understand and something I can treat. I've seen patients who've been receiving antibiotics for weeks, sometimes months, and the pus cells don't go away. And when we retest them in our lab, we find quite tragically that they don't have pus cells. So why this confusion? The reason is that most labs, when they look for pus cells, they'll take a wet prep, which means just a drop of the native semen, put it on a slide, put on a cover slip, and see it under the light microscope, and they will look at the round cells and count them as pus cells. However, in the semen, there are actually three kinds of round cells. There are the actual leukocytes, which you see to the left. Then there are macrophages that are normally present in semen. They don't represent infection. Their job is to eat up the dead sperm. And if you see a stained macrophage, you can see sperm heads within the cell. It's a scavenger. And then there are the immature sperm cells, the spermatids and the spermatocytes, which are also shed into the semen. And they also look around, of course. Once the slide is stained, you can see each of them have different characteristics: large nucleus, small nucleus, multinucleated nucleus, etc., etc. So therefore, it's very important that you talk to your pathologist that if you're seeing a large number of round cells, more than 5 per high power field, before you report them as pus cells, at least in those cases, stain the slide. According to the WHO manual, they should be using a stain known as peroxidase, which will go and stain the granules within the neutrophils. If they don't have peroxidase, at least any other standard stain, HNE, Papanicula, and they'll be able to distinguish through these characteristics which are the real leukocytes. If there are a significant number of leukocytes, then of course you may do a prostatic massage, prostatic fluid culture, semen culture, and all of that. But identifying pus cells accurately, very important, because it's a source of error and sometimes mistreatment for very long periods of time. Now, if you decide to do a culture, it's also very important how you do the culture, because 80% of patients who come to me with 2 or 3 semen cultures, all positive despite antibiotics, get cured just by repeating the culture in the correct manner. So what is the correct manner for a semen culture? It should be a technique that gets rid of all the commensals. So we tell the patient, when you go to the lab, carry a small bottle of povidone iodine and a bottle of boiled or distilled water. When you go there, apply povidone iodine on the penis, retract the skin of your not circumcised, apply it on the glands, apply it on your hands. Wait 3 to 5 minutes for the bacteria to die. During that time, go and pass urine so the anterior urethra is cleared of any commensals. Then with the boiled water, wash off the betadine very carefully from the glands, from the prepuce, from the penis, from your hands. Dry it with a clean towel, and then collect semen directly into the jar without touching anywhere or without putting your finger inside or without putting the penis inside. And you'll be amazed at the number of positive cultures that turn negative when collected this way. Not every infertile man needs a semen culture, but if there are significant round cells or symptoms suggestive of MAGI, accessory gland infection, then a proper semen culture is very important. So this is one of the first steps in the analysis, a very important step, and the interpretation of the semen has to be done carefully and correctly. You should know that it has been done in a good lab and that you're interpreting it, looking at the complete clinical context, and you understand that it is indicative but not absolute. Now, at the same meeting, hopefully has a semen report which is guiding you. If not, you've asked for a semen report, but at the same meeting, you will complete your history examination and advise some additional investigations. And the purpose of the history examination and investigation is, as we said, to assess for reversible and irreversible causes. Now, in history, the medical history is quite standard. You have a big table in every textbook. I'm not going to waste too much time on that, but I'd like to highlight the need for a good sexual history and bring that up later on after you've developed some rapport. Because if you just ask them, everything okay sexually, they'll always say yes. But after you've finished it, sometimes they ask this of the male alone when I'm examining him, and then again to the couple later on. That are there any sexual problems? What is your frequency of intercourse? Are you trying to time it around ovulation? Do you need to use any lubricant? Because any petroleum-based lubricant like lignocaine or KY jelly or petroleum jelly or water-based lubricants are spermicidal. They can kill the sperm. So there are special lubricants available which are sperm-friendly. Then post-intercourse, does the wife lie down? Does she go and wash immediately? In a small proportion of cases, this is the only critical history. And when you rectify the sexual part, the couple will achieve a pregnancy. Then the personal history, all of you are aware of this. What I should have added here, I have added it, the steroids, more and more young men. So if I get any young man who looks quite strong and muscular, I will always ask him about the use of steroids, sometimes directly or sometimes when his wife is not there because he wants to hide it. So cigarettes, more than 5, definitely more than 10 have an impact. Excess alcohol can affect the hormonal levels, stress, irregular diet, irregular sleep, anything that affects general well-being can affect sperm quality, and you need to inquire into that. Now, in terms of the history, if you look at the textbook, it's a huge table. Probably take half an hour if you were to ask them about everything in the table. Often I'll ask them a general question. Have you had any medical condition, any long-term medication, any surgery, any hospitalization? And that's it. And then based on the semen, I may ask some specific questions. So if it's an azoospermic male, then I will ask questions that can point towards causes of testicular damage, like mumps or surgery for UDT, or something that could point towards an obstruction, like an STD or a hernia surgery or a hydrocele surgery. If there's asthenia, apart from the general questions, recurrent respiratory tract infections that indicate chronic bronchitis, which would indicate ciliary dysfunction, or recurrent UTI, which would indicate, again, either infection or antibodies as a cause of the problem. And if it's oligo, then of course the whole general history, family history, etc. Now, after that history, examination is very important. And as I tell all my students that to do a good male infertility examination, you need to see 100 men with renal calculi, 100 fertile men with renal calculi, because then you will get a baseline feel of what is normal. In a fertile male, what does a normal size testes feel like? What is the consistency? What does a normal non-obstructed epididymis feel like, so that you can distinguish normal from flabby and normal from obstructed? What does the normal vase feel like? Every novice who has come and visited me, when he feels a patient with vasoplasia, usually will tell me, I think I feel a vase. Because identifying vasoplasia confidently is a clinical diagnosis, but in the beginning it's difficult. But after you felt 50 vasa in normal men and you've understood what that feeling is like, then when you're examining a man with vasoplasia, you'll be confidently be able to say that, okay, this man does not have a vase. Then the other things, phimosis and this and that, those are common things. But understanding the testicular size, epididymal fullness, and the palpability of the vase are very important in being able to make a distinction. And finally, of course, a cord to identify a varicocele versus funiculitis. If you felt enough normal spermatic cords, then you will know when there is a problem. So what to examine, every urologist knows, but how to examine, that is what I'm telling you, that you must examine more normal men to get an idea. This is a very simple tool, easily available on the net. Everyone should have it. You don't need ultrasound to assess testicular volume. That's nonsense. The Prader orchidometer is an inexpensive, standard way to judge within 10% error the volume of the testes. It not only helps you objectively identify the volume, but also helps you counsel the patient. So, for example, if I have a patient with Klinefelter syndrome or primary testicular failure, volume of 4 or 5 ml, I will hold the bead against his testes, match it, Then show the patient, see, this is your testis size. Then I show him the larger beads. That is the actual size that you need. And because of this discrepancy is the reason why your sperm count is only 0.5 million and why it's not going to improve and why you need to proceed to the next level of treatment. So very useful. So we've seen a patient who's come to us. We've taken his history. We've done his physical examination. We've correlated that with the semen reports, which we saw earlier. Now what next? Do we do a hormone test for everybody, antibody test, ultrasound, biopsy, genetic study? So that's going to be the next part of the talk. I'll just check how we're doing for time. Give me a moment. So good. We've finished 45 minutes. We have 45 minutes left, which will be enough time to discuss the further evaluation, genetics testing, and leave a little bit of time for question answers. So first question, should you, now that the patient has come, you want to impress the patient, you're a very good doctor, so do you send him for an infertility panel? I hate panels. To my mind, panels are for doctors who don't want to think. Every test that you ask for should be individualized. There should be a reason. There should be an interpretation of the outcome that leads to another action. So we'll not talk of panels, and we're going to ask that does everybody need a hormone assay? And the answer is no. In general, you will find that if the sperm count is more than 10 million, the hormones will be normal. There are variations to that. For example, if somebody has normal count but sexual dysfunction, prolactin could be high. But in general, from a fertility point of view, count more than 10 million, we don't bother with a hormone assay. If it's less than 10 million, definitely. If it's less than 5 million, then we want to look at the hormone test. Now, what is the minimum? Minimum would be FSH and testosterone. FSH because it will tell you about the spermatogenesis, and testosterone because it will tell you about the Leydig cell. If the patient can afford it, we add LH because sometimes there's a disconnect between the FSH and LH. One may be high, one may be low, and that may be an indication for a specific type of hormone therapy. And if the patient is obese, then we'd like to look at estradiol because sometimes the testosterone may be low because it's been converted into the estradiol. So if you have low T and high E2, that becomes an indication for use of an aromatase inhibitor. So usually this is what I would do. If you are an advanced center dealing with non-obstructive azoospermia, maybe doing research, then you might look at AMH, inhibin, and other things. One question people ask me, should we do free testosterone? The problem with free testosterone, though it's a very useful marker, is that all the labs in India assess free testosterone using an RIA method, which is very inaccurate. What is actually required is a reverse equilibrium dialysis method, which is not available. So even on the websites of the Andropause Society, etc., they recommend that rather than assaying free testosterone, you should use calculated free testosterone, which means you use total testosterone, SHBG value, and albumin value, and use a calculator that is available online to get a calculated value, and that comes closer to the actual biological free testosterone level. Now that's tedious, so we don't do that for everyone. Only if the total testosterone is in a gray zone between 200 to 400, and it matters to us to know is it really low or not, then we calculate free testosterone. Otherwise, we don't bother. If it's less than 200 total testosterone, even free is going to be low. If it's more than 400, free is always going to be normal. Prolactin is not routinely required in men who are coming only for infertility because unlike women where elevated prolactin is very common due to prolactin microadenomas in men, usually if there's a prolactin problem, it's because of a macroadenoma, which will then affect libido and cause ED. Mild elevations of prolactin will be common in men, 30, 40, sometimes 50, and that's either related to stress or some medication, and treating that will not have any impact on the fertility. Thyroid, D3, B12, they're not directly related, but they're quite widespread as a problem in men. And just to optimize their health, we'll often look at that and correct it if it's a problem. Now, why do we need testosterone in addition to FSH and LH? This is very important because sometimes people do only FSH, LH, and if a gynecologist has referred the patient, they will do FSH, LH, prolactin. So here is a man. You can see FSH very low, LH very low, not hypogonadal, but on the low normal side. When you look at, you begin to think, oh, we should give this man injections of HCG and HMG. But then you look at his testosterone, way up, upper end of normal. So in this case, obviously, he doesn't need any hormonal stimulation. His FSH and LH are low because of feedback from the high testosterone. They're in a perfect level of homeostasis, and you don't want to mess with this. On the other hand, same FSH, same LH, but if testosterone had been 250 or 300, then FSH, LH are inappropriately low normal, given the fact that testosterone is also low. And in that case, we would certainly want to give hormone therapy. So the question you're often going to be asking me in the next talk is, when do we give clomiphene or tamoxifen or injection HCG? The decision to give hormone therapy is based on the relative levels of FSH, LH, and testosterone. Okay, what about routine antibody testing? Should you do it for everyone? And the answer is you do it virtually for no one. Two reasons. One, that antibody testing has not now become part of many of the therapeutic algorithms. So whatever test you do, it doesn't help much. Secondly, majority of the labs test for antibody using the ELISA test. Now, the ELISA test will test for antibodies in the serum. So it is just testing antibodies to general sperm antigens, which were created after the sperm were denatured. These antibody titers in the serum have no correlation with the antibody in the semen, in the seminal plasma, and no correlation with the antibodies on the sperm surface. So positive ELISA test has no clinical relevance. If one really wants to look at antibodies, one has to look for sperm on the surface of the sperm head by using either the MAR test, the mixed agglutination reaction, or the IBT, the immunobead test, which will assess for sperm antibodies of AGG, AGI, specific type. There's somebody talking in the background. Can everyone check their mics, please? And then that could be used to decide whether this person may be given a trial of steroids. Many people don't do that. Or if the antibody titer is very high, then directly you recommend ICSI. Now here is the big one. Fundamental rule of surgeries: if you don't know what to do, investigate. A lot of urologists, patient comes for infertility, next prescription is ultrasound to look for varicocele. The truth is that you should not be sending patients for routine ultrasound to look for varicocele, because the guidelines are very clear that operating a subclinical varicocele, and subclinical varicocele means that clinically when you examine the patient is normal, but there is reflux only on the Doppler. Treating such a patient operating the varicocele of such a patient will not result in improvement. So in other words, if you don't suspect a varicocele, referring for ultrasound for varicocele is meaningless. Only if you found a varicocele and you're planning surgery and you want to confirm it, or you want to know what's happening on the other side, or if the patient has a tight scrotum and you have difficulty examining him, there you may consider an ultrasound, but routine ultrasound to look for a subclinical varicocele is of no value. If you're planning a micro TSA in a patient with non-obstructive azoospermia, then we want to rule out any intratesticular pathology, which is very rare, but still you'd want to rule it out before you open up the testes. So there one may do an ultrasound, but not a Doppler study for varicocele. So we need to be very clear about this, because too often I see urologists relying on the ultrasound to take a decision for varicocele surgery. Doesn't work that way. The decision to operate or not is based on your clinical examination. The varicocele is only documenting and validating your diagnosis. Now, what about testicular biopsy? Man is severe oligo. Will doing a biopsy guide his treatment? Or if a man has azoospermia, should we be doing a biopsy as the first step? And the answer is no. Actually, the whole approach to the diagnosis of azoospermia has changed. And we'll talk about that after 2 weeks when we talk about management. Therefore, a single diagnostic biopsy is no longer recommended. Even a diagnostic biopsy is combined with therapeutic biopsies. And an oligoid doesn't help at all. So in the past, when I was a student, I remember it was standard to do a biopsy in severe oligo or while operating a varicocele. We now realize that that has no diagnostic relevance. It doesn't change anything. So we do not recommend a biopsy in oligoastheno. And in azoospermia, we will combine the diagnostic biopsy, if indicated, with a therapeutic biopsy. If you do a biopsy, very important, never send testicular tissue in formalin. It will shrink to what you see here on the right side, and no reliable opinion can be given on this. This is the same biopsy cut in two. The right side was sent in formalin, and the left side was sent in Boyne's fluid. Boyne's fluid is formalin, but it also has picric acid and glacial acetic acid. And these two work together to preserve the cellular and nuclear integrity. So when you look at the left, you can appreciate complete spermatogenesis, including all cellular types. When you look at the right, you can't see anything. You have to imagine what each shape probably is. So now what else? Hormone testing, antibody testing, ultrasound, biopsy. Are there other tests? In the 6th edition, there's a whole bunch of tests described. There's the basic examination, which we said count, motility, morphology. There's an extended examination, which is sperm DNA fragmentation, but many other tests. And there are advanced examinations, which includes reactive oxygen species, CASA computerized semen analysis, sperm chromatin, transmembrane flux, etc. Which of these do we actually do practically? Now, CASA is computerized analysis of sperm. And it's interesting because CASA can give you sperm motility characteristics, which you can never pick up during a manual assessment. So you can see, is the sperm moving in a curvilinear manner? What is the linear velocity? What is the path velocity? What is the curvilinear velocity? And there were papers in the past suggesting that these parameters give additional prognostic information. The problem is that the original machines were very big, very expensive, and just because they were computerized didn't mean they were automatic. They still needed a high level of fine-tuning by the technician to adjust for the amount of debris in the semen, to assess the amount of light coming through, to assess the image analysis, and a lot of effort was needed. So they remained tools in major laboratories. This may change in future because now these kind of AI-based small portable semen analyzer are becoming more and more popular. And as they're doing more and more samples and AI learning is happening, they're becoming more and more accurate. For example, in this device, you'll take a native sample, put it on a special slide, put it in the machine, and 5 minutes later, while you're talking to the patient, you have a whole computerized analysis, which in comparison to standard manual methods seems to be quite accurate. There is one shortcoming of this which you need to be aware of, because you will increasingly seeing semen reports that come from labs that use a computerized semen analyzer. If you look at the normative data to the right, measurement range, look at concentration. It says less than 0.1. It doesn't say 0. The problem with these machines is if there's an azoospermic sample or a cryptozoosermic sample or a very, very low sperm count, then they can get confused and they may not be able to report on the presence of a very low sperm count or tell you confidently that no sperm are present. So while these are machines that as they become cheaper will probably become quite standard in andrology clinics and labs, they still have some limitation which will need a technician to step in if the sample is azoospermic. So just be aware of that. Now, what about sperm function testing? 30, 40 years ago, that was a hot topic. We had tests to assess the ability of the sperm to penetrate through the cumulus, to bind to the zona, to penetrate the zona, to enter the egg. Fancy tests like the zona-free golden hamster egg penetration test, where we would incubate human sperm with eggs from the golden Chinese hamster and see whether they could penetrate, fertilize, and decondense into a progamete in the hamster egg. All that was very interesting till ICSI, intracytoplasmic sperm injection, became the norm. Once you were able to take a sperm and inject it directly into the egg, all the other steps became redundant. And for that reason, sperm function testing, which was fascinating to do and talk about, has completely fallen by the wayside. Only one test has remained, and that relates to sperm DNA integrity testing. Now, we know that the sperm is a double helix structure, and we know that with certain stresses, either there can be a break in the single strand or in both the strands, and these are measured by a variety of tests. When this was first reported, and that's more than 25 years ago, it seemed like this was a fantastic test because the first paper that came from Everson using what was known as a sperm chromatin structural assay, which is a flow cytometric based test, stated unequivocally that if there's less than 75% fragmentation, pregnancy rates very high, more than 27% fragmentation, no pregnancy. In fact, the early papers made it sound like the sperm DNA fragmentation testing was more useful than a semen analysis in deciding whether a couple would achieve pregnancy or not. We realized that yes, high sperm DNA fragmentation will result in lower natural pregnancy, lower IUI pregnancy, lower IVF fertilization. ICSI doesn't seem to be affected in terms of fertilization rates, but early embryo loss and early recurrent pregnancy has also been attributed to this. So you would think that this is the most important test to do. And yet today, 25 years later, sorry, somebody called and I'll have to switch that off. Okay, can you verify that we are still seeing my slide?
Yes, sir. We can see your slide.
Sure. So one would have thought that this is the best test to do. However, what we realize now is that even today, in the guidelines, sperm DNA fragmentation is not recommended as a first-line test. And the reasons are several. One, that there is a lot of inter-test variability, and you can see 4 different tests here for measuring sperm DNA fragmentation. There's a lot of intra-individual variability. You do a test now and later, and there's a different finding. And very important, the cutoffs seem to vary. So here was a very interesting study. Same semen sample subjected to sperm DNA fragmentation by 6 different methods. For each of the methods, the cutoff to be used was different, and the same sample by one method was labeled as having a pathologically high fragmentation rate, and by another method, it was labeled as normal. So because of all these difficulties in standardizing and in interpreting the test, sperm DNA fragmentation remains a very useful test, but not a first-line test. We would do it in couples who have been trying for a while. Everything seems normal, sperm count normal, wife normal, but there is unexplained infertility. Then we want to know, is the DNA fragmentation the cause? Or they underwent IVF, but there was very poor fertilization, or they underwent ICSI, but there was repeated failure of implantation, or early pregnancy loss, or if somebody has a varicocele with semen parameters in the gray zone, and you're looking for one more reason to perhaps recommend surgery, then if the sperm DNA fragmentation is high, you may recommend varicocele surgery, because varicocele surgery is known to lower the DNA fragmentation by 5 to 7%. So it's not the first line test, but it's still a useful test. You will see it being increasingly used. The commonest test used in most Indian labs is the halo sperm test, where 30% is the cutoff. If you have an advanced lab using tunnel, then 14 to 20% would be the cutoff. So in summary, you have the semen analysis, and you should be further guided by proper and judicious use of the investigations. Now, with this, I'm going to just pause and see if there are any questions on what we have talked about, and then I will move to genetic testing. Any questions, doctors?
Yes, sir. Yes, sir. No questions. Would you like to take few questions, sir?
Yeah, we'll take 5 minutes of questions, and then I'll keep 15 minutes for genetic testing.
Yeah. So there's a question from Dr. Sanjay Natarajan. He's asking, how much improvement in semen analysis do you see in your practice after a surgery for clinically significant varicocele?
You have to wait 2 weeks for that answer,
Okay.
because
Is
that's
that-
when we're talking of therapy. So right now we'll take questions on the diagnostic part.
Okay.
When we talk of therapy, varicocele, etc., we'll give those figures.
Sure, sure. Okay. The next question is from Dr. Keshav, sir. He is operating on varicocele, which is diagnosed clinically, legally okay without an ultrasound examination, especially when the outcome is not so good.
So, I mean, that depends on your practice and whether you need, if you feel the need for a legal documentation. But I will often operate based on my clinical judgment. More often, I do the ultrasound if he's trying to claim insurance. Or more often, if there's a left clinical varicocele, but the right side is doubtful, I will do the ultrasound to get more validity on that side. In fact, even there, I actually do the Doppler myself. I don't refer out for an ultrasound.
Okay, sir. Thank you. Another question from Dr. Prashant Mulavkar. When do you take the testosterone sample? Be at 9 o'clock in the morning with nil orally, or is in a specific time period?
No,
collecting?
testosterone always has to be assessed early morning when it's at the peak, so somewhere around 8 a.m. Should the patient be fasting? That's controversial. Some guidelines say yes, some say no. I tell the patient you can have a cup of tea, but don't have a heavy breakfast before your test.
Okay, okay. Another question from Dr. Naman Agarwal. Where can I purchase a Prader orchidometer?
Online, lots of sites offering it.
Okay, sir. A question from Dr. Pradeep Kumar. What should be the ideal waiting time for vaginal washing or maturation following ejaculation? I think for female counterpart.
If a couple is trying for pregnancy, we tell them that if you're having sex at night, don't wash the vagina inside, just wipe the outer area.
Okay. So another question from him. Instead of semen culture, can we do prosthetic massage and collect urine?
You can. I mean, there are various ways of skinning the cat, but semen culture would be more specific for the semen.
Okay, sir. The question from Dr. Keshav, sir, again. The labs do not mention whether they have used a stain before reporting on pus cells. Is it very important?
It is very important. So that's why it's very important, if you're establishing a practice in andrology, to have 1 or 2 labs whom you trust and with whom you can have a dialogue. And even whether it is testing for fructose or checking for pus cells, you need to know that the lab is doing it the right way.
Okay. The question from Dr. Jawahar. Do children of Cartagena syndrome men inherit subfertility or infertility?
Good question. I've actually not come across the answer to that, but it's likely to have a genetic basis, and I would expect that they would inherit it. But is it autosomal recessive or dominant? I don't know. I'll read up about it. We know that in YQC microdeletion, for example, that will 100% be inherited because it's linked to the Y chromosome. So if there's a male child born out of sperm retrieved in a man with YQC microdeletion, that boy will definitely have the same deletion. But Cartagener's, where is the gene located? Is it autosomal? Is it recessive? We'll have to check that.
Okay, sir. The question from Dr. Divyanshu, the relevance of underwear at the night in the history taking.
So I tell patients not to wear a tight underwear at night. Does it really matter? We don't know. Once upon a time, the Japanese had made a thermal underwear as a means of uh, fertility control. So in general, reducing heat may help. Okay, last question, and we'll move on to the last part of the talk, which is genetics.
Yes, sir. So I have a question, sir. All this time you have been discussing about the importance of semen analysis. It is so vital in evaluation of infertile men. Should you feel that an andrologist should be trained in interpreting the semen sample? Andrologist, should he himself do semen analysis and interpret it?
So
What do you
actually,
think?
if you go globally,
Hmm.
andrology is a very variable term. In India, in USA, an andrologist is a surgeon, usually a urologist, who's providing surgical andrology. In Egypt, for example, the andrologist is not a surgeon. He's trained in STDs, medical management of male infertility, and semenology. A surgeon is not going to sit and look at semen samples. So while it is ideal, I think the correct answer to that is that, again, work with one pathologist and encourage him to have one person only trained in semenology who attends a certified course in the correct methodology. But I do feel surgeons should learn how to read the testicular histology because often pathologists make mistakes.
Oh,
Okay,
thank you.
so we'll move on to the next part of the talk, which is the genetic testing. Where has the talk disappeared to? I think I'll have to stop share and find the talk. I'd opened two presentations, but I think one call came and that has disrupted the presentation. Are we seeing genetics of male infertility?
Yes, sir. Slides are visible.
Okay. So genetic testing is not indicated in every case, but in selected cases, it can be very, very useful. So this is going to be a brief talk just explaining when genetic testing is required. Now, the number of uh, data points that can be accumulated from genetic testing. We can look for numerical defects like Klinefelter's, structural defects like translocations, microdeletions, which are pinpoint deletions too small to be seen on chromosomal testing, single gene mutations, which I think are going to be very important in future when we do whole exome screening, epigenetic factors, which are gaining more and more importance and which we are still understanding, and similarly the mitochondrial genome, which is also gaining increasing importance. For the time being in this talk, we will talk about what is standardized, which is basically three types of tests: the karyotype, the YQ deletion, and the CFTR testing. And we'll talk about when each of these is to be done, which test, how to interpret the test, and what is the final clinical implication. Now, there are two very distinct clinical entities. There's obstructive azoospermia and there's testicular failure. And the testing for these two is different. Very often I see people doing all the tests for either of the groups, which actually just indicates ignorance. So if we are looking at the test for obstructive azoospermia due to CBAVD, congenital bilateral absence of the vas deferens, what is the genetic test that we need to do? We do a test called CFTR mutation testing, which is cystic fibrosis transmembrane regulator gene. You don't need a karyotype in CBAVD. You don't need a YQ microdeletion. Most cases of CBAVD are thought to be a localized phenotypic manifestation of a CFTR mutation. The CFTR gene is located on an autosomal chromosome, number 7. It's a long gene. It is responsible for coding certain proteins that transport chlorides and other substances across the cell membrane. And therefore, in its absence, the tubular structures will collapse. So being a very large gene, there are a huge number of mutations. So doing a small panel of known mutations doesn't suffice. And these mutations are again either minor or major. And it is important to distinguish between minor or major because they have different clinical implications. If you have a major mutation on both the chromosomes, that will produce cystic fibrosis, which is a life-threatening, life-shortening disease. To do IVF ICSI to produce cystic fibrosis is not acceptable. If it's only a minor mutation, it will result in vas aplasia, which doesn't affect health, will affect fertility, but with a solution. So, for example, the dark circle is a major mutation, the hollow circle is a minor mutation, the empty circle is no mutation. So, depending on what mutation the man has and whether the wife is a carrier of a mutation or a non-carrier, various combinations are possible. If the man has a major mutation and the wife is a carrier of a major mutation, but both are homozygous, therefore they don't have, both are heterozygous, so therefore they don't have cystic fibrosis. But when they come together, there's a 1 in 4 chance that the child might inherit the major mutation from them and have cystic fibrosis, which is very bad. On the other hand, if the third possibility, if you look at, if the father has only minor mutations, he's homozygous for minor mutations, and therefore has CBAVD, and the wife is a carrier for a minor mutation only, then there is a 1 in 4 chance that the child, or a 1 in 2 chance, have 50% chance that the child will have CBAVD and a 50% chance that he'll be normal. If the wife is a non-carrier and the husband has only a minor mutation, probably the child may not have anything. So that is why knowing which mutation is present is very important. And we also need to know that there's a marked ethnic variation. White Caucasians have a very high frequency of CFTR mutation and a high frequency of major mutations like the delta 508. The delta 508 is loss of a phenylalanine. And it's a major mutation with severe consequences. The 5T is a poly-T variant on the intron, and that is a minor mutation. And if you look at the Caucasian population, the delta 508 dominates. If you look at the Egyptian or the Japanese or the Chinese population, the 5T, which is the minor variant, dominates. And we did a study on the Indian population, 80 patients from all over the country, to see what is common. And once again, we found that like the other patients from the Middle East and South Asia, The Delta 508 is only in about 8.75% of Indian patients, and the poly-T variant, the C1210, is there in almost half the patients. So luckily, most of our patients with cystic fibrosis, with vasoplasia, are not at risk of getting cystic fibrosis if you were to aspirate their sperm and do IVF ICSI. But in our whole group, we did have about, I think, 9 patients where the wife was also a carrier and the husbands in 3 cases had a major mutation, and there was some risk that the child could have not only vasoplasia but also cystic fibrosis. And therefore, currently, at least in all my vasoplasia patients, we do a complete screen of the CFTR gene because the panels which are available as kits come from the Western population. And what we have found is that the mutations in the Indian population are quite different from the Western population. Therefore, gene panels don't work. We do a full gene screening for any mutation, and then based on what is there in the husband, we decide whether we need to screen the wife, and thereby we are able to give them the accurate risk to the offspring. Now, if it is CUAVD, CUA is congenital unilateral absence of the vas deferens, then the picture can be quite different. In many cases of CUAVD, the kidney is also absent on that side. And these are men where the problem is not due to a CFTR mutation, but they are due to a mesonephric duct abnormality. So if there's a unilateral vasoplasia with renal agenesis, we are not worried. Few cases of CBAVD also have unilateral renal anomaly, and there too, we usually don't find a CFTR mutation. On the other hand, if it's a CUAVD without a renal anomaly, then again, we would want to do a CFTR testing. So the first message is in obstructive azoospermia. Due to a congenital condition, the testing to be done is for CFTR mutation. Now, if you're looking at primary testicular failure, where it's a non-obstructive azoospermia, there you don't do CFTR. Instead, we look at karyotyping to look for numerical anomalies, and we do YQ microdeletion testing to look for microdeletions on the long arm of the Y chromosome. So the first thing, karyotype, is to look typically for Klinefelter syndrome, which is the commonest genetic abnormality causing male infertility. Classic is 47XXY with other variations possible. Now, very often the phenotype may not reflect the classic image, tall, obese with gynecomastia. Many of them look completely normal. But invariably, all the Klinefelters I've seen, and I've seen quite a large number, they all have very tiny testes, ranging from 1 to 3 or at the most 4 ml. Most of them will have elevated FSH. Testosterone varies. Testosterone may either be low or low normal. The higher the testosterone, the better the chance that even this man with Klinefelter syndrome may have a few sperms. So prevalence, 0.1% of the general population, that's quite high. 3% of all infertile men and almost 10% of all azoospermic men. So you will encounter Klinefelter syndrome. The important reason why you should diagnose it is because even in Klinefelter syndrome with tiny testes, very high FSH, some of these men may still harbor sperm in the testes, which can be retrieved and used to produce a viable pregnancy. Something is missing text here. This slide should have actually said that the chance of finding sperm in Klinefelter syndrome in literature ranges from 30 to 50%. Our experience has not been so good. I've spoken to other colleagues also all around India, and most of us find sperm only in about 1 out of 8 patients. So that's somewhere like a 10 to 15% chance of finding sperm. However, I have a population of patients whom I've operated in Dubai, and there the sperm retrieval rate was 50%. So I think there is again an ethnic variation. Now, the big question you will want to ask is that if we do find sperm in Klinefelter syndrome, is it possible the sperm will be abnormal and the child will be abnormal and the child needs to be screened? Surprisingly, follow-up of children who've been born after sperm retrieval in men with Klinefelter syndrome has not shown any abnormality. So the thinking is that we find sperm in those cases where a few cells somehow escape the abnormality. They are genetically normal, and it is those cells that go ahead to form the sperm. So therefore, the conclusion in the second article that pre-implantation genetic testing might not be necessary in male patients with 47XXY who are undergoing IVF-ICSI. Now, why microdeletion? Looks at the fact that sometimes very small amounts of very important genetic material may be lost. And this loss is so small that it is not seen on a karyotypic screening. But if you look for this loss using PCR and STS markers, sequence tag markers, then you can identify these losses. So there are regions on the long arm of the Y chromosome labeled as AZF A, B, and C, azoospermia factor A, B, and C, where you can detect various losses of small areas. You can see all the markers that can be seen. Now, why it is important to identify these losses, these are all the markers that are tested using an STS-based PCR. The three main regions are AZF, A, B, C, and some people call the terminal region of C as AZFD. The reason why this is important is that about 5% of men with azoospermia and maybe 1 to 2% of men with severe oligozoospermia have these deletions. If sperm are found in men with these deletions and a male child is born by IVF-ICSI, the child will definitely inherit it. And it has a prognostic significance. If there is a deletion in the AZF-A or AZF-B regions, usually there are no sperm to be found, even if you do microtessay. Though sometimes if the deletions are very small, rare case reports, you do find sperm. That's why the AUA says you can't absolutely say no. But in general, if somebody has AZF-A or B, we will tell them, don't worry. If it is, don't attempt anything. If it is AZF-C, again, literature says in 60% of cases, you can find sperm. In our experience, not so good. We find sperm in maybe, again, 15% of cases who have had AZF-C deletion. And as I said, if we do find it and a male child is conceived, he will inherit this defect, and that has to be part of the counseling. Finally, translocations, where the material goes from one chromosome to the other. If there's a translocation from an autosomal chromosome to an X or Y chromosome to the sex chromosomes, then that can sometimes impair spermatogenesis and be a cause of oligoastheno or azo. More often, translocations between autosomal chromosomes will not cause infertility in the individual, but will be a cause of recurrent pregnancy loss because after conception, there will be imbalanced chromosomes. So we typically look for translocations in couples with RPL, recurrent pregnancy loss. So to summarize, genetic testing will help us understand the etiology of some causes, some cases of azoospermia, and some cases of severe oligozoospermia. The type of genetic defect may help us plan therapy or exclude therapy, and also know whether there are any risks to the offspring. So we do genetic testing in all these conditions, but remember, if it's obstructive azoospermia, it is only CFTR. If it is non-obstructive azoospermia, it is karyotyping and YQ microdeletion. If it is oligoastheno, karyotyping and YQ microdeletion. If it is recurrent pregnancy loss, only karyotyping. So with that, I think we'll just move on, end the talk here. because in future we're going to be looking at whole gene or whole exome sequencing, looking at every gene responsible for spermatogenesis. Maybe we'll combine that with a messenger RNA seminal plasma mapping, and combination of all that will be far, far more accurate in identifying the causes. So it's exactly 9 p.m. now. Maybe we can take 2-3 questions and end the session. Thank you very much.
Thank you, sir. There are a few questions, but not on genetics. Would you like to answer?
Sure.
Question from Dr. Yogendra. Can we use normal saline in place of bovine solution?
No, it has to be preserved in boins. Only then can you prepare the slices and sections.
There's a question from Dr. Chandramohan Godala. Is there any difference in the size of the testis in Asian and Western population?
Western norms that they give tend to be a little larger. My feeling is, yeah, it may be a little smaller. I've not seen comparative data, but based on, again, having practiced in 2 different populations, I would say Asian tends to be a little smaller.
Then this Prader orchidometer would apply for our
Prader
population.
orchidometer just gives you the objective test. You have to decide whether what you measure is normal or not.
Okay.
The Prader won't change from country to country. The Prader is just a ball of a fixed size. So if it's 15 ml, it's 15 ml. The only difference is in an Indian male with 15 ml, I will call him normal, whereas a Caucasian with 15 ml, I may say slightly smaller than normal.
Okay. Okay. So another question is, should we operate on the opposite? I think this management will talk in next session.
Next time, yeah.
Yeah. These are the questions. So thank you very much, sir. In spite of having a bad cough and bad throat, you could speak continuously for 1.5 hours. Hats off to you, sir. Thank you so much.
Only because I was speaking. Now I'll be coughing for the next half.
We really bothered you so much, sir. Thank you so
My
much.
pleasure. Thank you very much.
Thank you, sir.
Wish all of you a good night. And honestly, if you have questions, mail them to me. We'll answer them next time. And even if you have questions about treatment, you can send them to me. So I'll incorporate those answers in the talk.
Thank you, sir. Dr. Keshav, sir. In the
Thank
final.
you. Thank you, Dr. Upin, for a master class. It was truly a master class.
Thank you very much.
Thank you, sir. Thank you so much. Thank you, everyone, for joining this session. This is recorded and the session is available whenever anybody wants to see. You can go to the e-learning platform of USI and watch the session again. Thank you, sir. We'll see you again after 2 weeks. Thank you, everyone.